So, without further ado, if we can move on to the first of our speakers, Dr. Tim Butler, who's an extremely experienced general practitioner and who is also the co-chair of the CVD Prevention Network. Tim is a GP and works clinically regularly. He's also the Assistant Medical Director for NHS England and NHS Improvement for the North Eastern Yorkshire. And there's nobody better placed to give us the national overview of cardiovascular disease prevention and a little bit of information about what that's going to mean for us in the North East and North Cumbria. Thank you, Tim.
Thank you, Jane. Can you hear me okay, everybody, or Jane? Yes, I'm just checking. Very good. Okay, thank you. Next slide, please. All right, okay. I had my subtitle, which I got today. I don't need to introduce myself because Jane has done that. Thank you very much, Jane. I was asked to talk about CVD prevention, the long-term plan, alignment to ICS priorities, inequalities, and the COVID era. And I thought, crikey, I'll get all of that in 10 minutes. So this is going to be a whistle-stop tour, a little bit of background. I'll talk more about the long-term plan to give you a sort of context where this is coming from. The long-term plan was published in January 19. It was published after a period of sort of very poor growth in the NHS. The NHS since 2010 has been funded approximately 2% per year. And this was against a background of increasing demand of approximately 4% per year. And by 2017-18, we had this £20 million gap in NHS funding. The result of that was that we had significant pressure on our services. If we look at what we were actually spending our money on in the NHS, that next slide, please. And we can see from this donut that small little bright green section on the top left is the prevention budget, which was about 6.5% of the NHS budget. The dark blue and the dark green were spent on acute care, treatment, managing illness. So the challenge was, how do we do more of prevention is better than cure? The difficulty we had, though, next slide, please, is that this is spent since 2018, or spent since 2013, pegged. And we can see that the light green bar hasn't grown at all over the last 5 years. So the problem was, how do we get the growth in the NHS and do more on preventative care? That was the argument between the NHS England and the government in 2017 when there was a funding deficit. Next slide, please. So the government agreed a 3.7 per year funding for the NHS. It should be noted that this was less than the 4% which was estimated to be needed. So things are still going to be tight. But in return for that 5-year guaranteed 3.7 per year funding, government asked the NHS to come up with a new way of doing things. And that was the birth of the long-term plan. It was new models of care. It wanted integrated cross-organisational working using ICP and ICSs. It was a shift towards a prevention agenda, a shift towards tackling inequalities in a digital environment. Next slide, please. So again, this really sort of echoes what I've just said regarding, and I should add to that, that third point there was tackling the workforce challenges and supporting primary care. Next slide, please. Okay, so in the Northeast, we developed our ICS and ICP structure. We'll remember our engagement events, which occurred through 2019. And the vision from that first point, to fundamentally shift outcomes. Now, there was a concentration on health outcomes rather than activity, to improve healthy life expectancy, to raise the quality and effectiveness of our primary, community and secondary care, to jointly value our staff and workforce, and to harness the power of information. So that was the vision of our ICS, and we developed that vision. Next slide, please. Following on from that, we developed our priorities, which was improving population health, the shift, as I said, to prevention and early detection, and the effective management of conditions. Also, in those priorities, the making every contact count, and also the targeting of interventions on those at greatest risk of poor health outcomes. That last point is directly addressing the inequalities agenda. But this is a cardiovascular meeting this afternoon. So within the long-term plan, there was a call to prevent 150,000 heart attacks and stroke and dementia cases per year. We must recognize that CVD is now and still 27% of mortality in England at the moment. Next slide, please. So if we look, what does cardiovascular prevention mean? You may not be able to see the detail of this in the slide the way it's produced here, but the risk factors that attribute to it, the top one there is blood pressure. I'll read those out. Blood pressure, dietary issues, high cholesterol, obesity, tobacco, diabetes, inactivity, air pollution, kidney function, alcohol, and occupational risks. But those, to address cardiovascular prevention is a system approach. If we think about tobacco and dietary issues, that requires government, it requires legislation, it requires the industry standards. But if we consider what's within our remit within the NHS, the big one there, high blood pressure at the very top. The third one down there is cholesterol issues. And I think that's the essence of the NHS strategy on cardiovascular prevention. Next slide, please. If we consider what we've achieved over the last 40 years, we have really achieved a great deal. Cardiovascular disease has dropped enormously. Over 75% of cardiovascular disease has been removed due to the hard work, better work of us all within the NHS and in wider society. Next slide, please. But what has happened really since about 2013, 2012, 2013, is that we've seen widening inequalities. I highlighted here South Tees CCG. I could have picked other areas where we've actually started to see cardiovascular disease incidence start to rise again. And just put that into context of what's been happening over the last 40 years. That decline has come to an abrupt halt. As well as that, we can see on the black line here, it's continuing to fall, albeit slower for the rest of England. So that suggests inequalities is becoming a much more of a problem and something that needs to be urgently tackled. Next slide, please. Thank you. So just to remember, as I mentioned, cardiovascular stats is still a leading cause of death. Just to remember, 27% of all mortality, 100,000 hospital admissions. Stroke remains the fourth biggest killer in the United Kingdom with 36,000 deaths per year. And the healthcare costs associated with cardiovascular disease are substantial. Next slide, please. So NHS England published this graph. This was a call to action, really, on the three big issues within our gift: AF, high blood pressure, and high cholesterol. Now, I don't want to spend much time on this today because we have talks later on AF, high blood pressure, and cholesterol. What I do want to just really highlight is that middle top figure on blood pressure, that 80%. That's a call that we need to detect 80% of the expected prevalence in our population. This area we're not doing too well on. We're detecting somewhere between 45 and 60% of the expected amount of cardiovascular disease in our population. I think we can do more on that figure. The management of blood pressure at that 150/90 target, we are actually doing very well in the Northeast, with over 85% of people treated to target. So there's areas that we have done very well on, but there's still areas for more work. Next slide, please. So putting that in the context of COVID-19, COVID-19, as you will be aware, has been horrendous for everybody. But it continues to follow the fault lines of inequality. And it is really striking that it almost mirrors cardiovascular disease. We see that those in the poor neighborhoods are twice as likely to be killed by the virus. Preventable conditions, including cardiovascular disease and type 2 diabetes, are major risk factors. So the risk factors from dying and morbidity from COVID are the same risk factors for cardiovascular disease. So treating inequalities in particular is managing cardiovascular prevention and managing COVID at the same time. COVID has shone a light on inequalities for us. Next slide, please. So in summary, the long-term plan was a call for new models of care with a focus on outputs and quality. It was a call for cross-organizational working, where we work across many providers, local authorities, third sector, BHF, Heart UK, many others. It was a call for a digital environment, which with COVID has actually produced a real tenfold increase in our uptake of digital technologies for healthcare provision. And I would say tackling CVD prevention is tackling health inequalities, and we see that even more so within the COVID era. And next slide, please. And finally, it's the only picture I could get with Durham Cathedral with its mask on. So thank you very much. And I think I stuck to my 10-minute slot. Thank you. That was very fast.
Thank you, Tim. That was very well kept to time. So thank you for doing that. And that's an excellent overview of contextualizing CVD prevention in the broadest sense. We're now going to move on. And Dr. Joe Chadanika is working with us in the AHSN, but he is the national program lead for the CVD prevention program, in particular with regards to optimizing lipids and the familial hypercholesterolemia program. He's got a background in cardiovascular disease and also a background in public health, so he's extremely well placed to take that on. Joe, thank you.
Thank you so much, Jane, and thank you for inviting us to share our program. And I have to say thanks again to Tim for the background there. It's really a good backdrop in why we're now focusing on lipids as one of the cardiovascular disease topics. If we can go to the next slide, please, Sarah. I won't dwell much on this. As Tim has said, the backdrop is really around tackling inequalities. And this is just a slide to remind us why we're focusing on cholesterol, one of the ABCs of the program. But we do know that a quarter of all deaths from CVD are related to elevated cholesterol. We also know that after blood pressure, cholesterol is the most significant medical risk factor. We also know that actually cholesterol or high cholesterol is quite common, and FH, about 1 in 250 or 1 to 200 to 500 people do have FH, for example. So it's actually a quite common condition, but managing the treatment of cholesterol or identifying people who need a diagnosis or treatment is really the focus of our program here. But we also know that for every unit reduction in high cholesterol, there's actually a significant reduction in major cardiovascular events later on in life. So this is a really important area. And as well, any intervention that would lower cholesterol will have a significant impact in terms of recurrence of coronary heart disease complications later on. If we can move to the next slide, please. This is just our own summary or depiction of the National Lipid Guidance, which we produced earlier this year by NICE. I have to reiterate, there is this guidance, but there's also the statin intolerance guidance. But as you'd see, if you've viewed seen the guidance before, purely it is just a nice flow chart on how to manage lipids, either in primary care, where on the green side there, where we've got NHS health checks, or in primary or in secondary care on the right-hand side. And again, it's quite systematic. But I think the important thing to emphasize here is that there is a combination of doing systematic searches, but also further on referral for people who need high-intensity statins. And you can see in the blue bit in the middle there, that is a direct focus on people who've got suspected FH. And again, there's either systematic diagnosis of these people, but also either in primary or secondary care, there is actually opportunistic detection of these people. So the point of emphasis here is that these are the nice guidance which are widely available, and we are really working with our partners to just encourage the systematic adoption of these protocols. On the next slide, please, Sarah. This is kind of the program which we envisage that our partners and us will provide. It is pretty much a call to action for us in terms of the parts which we need to be focusing on. But I appreciate that it's not very easy to put the whole program in boxes. So this is just a synopsis here of the key areas. So starting from the left there, any kind of health checks, whether it's health MOTs or annual medical reviews, or immunization, the point of immunization for children, or NHS health check. We were just trying to encourage a systematic approach in terms of how health checks can be important in identifying the people who need to be in the lipid program. But follow on from that, database searches using different search tools are also helpful to identify people who need lipid optimization. And that could be through tools in the Northeast here, like CDRC or Primus or FarmCat. But the other one there is just CVD Prevent, which again gives us high level data of the risk factors within our region without being very specific to patients. So all those tools and databases are quite useful within our program to highlight people who need further interventions. But also in specifically looking at FH case finding is another particular area of focus for us. Again, there's primary care database searches, but we're also looking at the genetic hubs or the child parent screening pilots, which we are currently out for expressions of interest, or cascade testing. So that's an element of the program where we know that early detection and systematic application of case finding will help us find those missing thousands, so to say. But the other end of the program there, you would see the primary prevention, where we're talking about people who've got who are at risk of CVD, or secondary prevention, those who've had an episode. There's a clear pathway there. But the take-home message here is around optimizing, the medication or the treatment for those people who've been identified, or systematically trying to identify those people. But again, further down in the green bottle, in the green diagram there, we are also promoting new lipid lowering therapies. Some of them are actually approved and being used now, but there are some which are subject to NICE approval, which we also promote. But clearly, there is also a pathway for FH patients who are within the system. Next slide, please, Sarah. I won't dwell much on metrics, because I think it is an important element, but this is an element where within our program we're working collaboratively with a lot of our partners to draft really tangible metrics. So I think the take-home message from me here around the metrics, that other than that they are in development, but we really are looking at the full program from identification to treatment, for it to align to the long-term plan targets, which I think team nicely alluded to there. So 25%, for example, detection of people who who've got FH. But we are working with our partners to ensure that every area of the program is represented within the metrics here. On to the next slide, Sarah, please. This is just a quick revisit on the FH element of the program. So there's two ways where we would be able to find patients within the program. So on the right-hand side, they mentioned the database searches, which could be systematically done, whether in primary and secondary care. But on the left-hand side, that's the pilot which I referred to before around child-parent screening. And again, as you would see, both pathways, either way, of our patients coming into the program, they will go through a genomic hub where the results are analyzed, sent to the GP practices. Then we try to case find those, or we do the cascade testing to ensure that there's a follow-up through our clinicians and identify the families who need to be brought into the service. So to me, this is an element of the wider program, but it just shows you the pathway in terms of referral. On to the next slide, please, Aaron. This is pretty much the last slide, but it might be very small print, but it is just a depiction to say we're not standing alone in this program, so to say. We are working with our national and regional partners. So we've got a project team of 15 AHSN project managers within the lipid program who would work together to identify barriers, good practice, but also link with the lipid steering group, which in turn reports into the CVD prevention development group. Ultimately, we work with our NHS England colleagues to ensure that although the lipid program is an element of the CVD program, it is represented at a wider stakeholder level with our NHS England colleagues. So there is a pathway in terms of how our program is fed into in further up above, so to say. But we will be able to share this slide after the presentation. I think that was my last presentation, Sarah.
Okay, thank you, Joe. That's an excellent overview of how optimizing lipids and FH sits nationally. Next, we welcome Professor Julia Newton, who's the medical director for us in the AHSN Northeast North Cumbria, and she's going to give us a more regional view. Julia is, I've known Julia for many years. She has an extensive knowledge and background in both clinically, academic, and taking on managerial roles, and extremely well placed to act as medical director for us, and also to be a program lead for optimizing lipids and FH. Thank you, Julia.
Thanks, Jane. Next slide, please, Sarah. Yeah, so thank you for that introduction. As Jane has said, I'm a clinician, but I don't work in lipids. I'm a geriatrician by background. I've been medical director for the AHSN for almost 3 years now. And one of the programs that I'm most proud of is the familial hypercholesterolemia program that we've delivered in the south of the region that you'll hear more about later on. But the intention now is to take what was that homegrown program and roll it out across Northeast North Cumbria and beyond across the other 14 AHSNs. So the purpose of my talk really is just to focus on what we're trying to do in Northeast North Cumbria around familial hypercholesterolemia. Just a little bit more background about FH to just build upon what Joe has described we're aiming to do nationally. For those of you that aren't aware, familial hypercholesterolemia occurs in about 1 in 250 of the population, so it's a really common gene. And if it's not treated or identified, then individuals have a significant risk of having premature cardiovascular disease. So to put it into perspective, about 50% of men will have an MI, so a heart attack, by 50 years of age. Current estimates suggest that only 7% of patients with familial hypercholesterolemia have been identified. And if you have it, if you have the gene, then and you're treated with tablets to reduce your cholesterol, usually statin tablets in the first instance, which cost pennies, then your risk reverts down to almost negligible. And that 7% is hugely variable across the country, with some areas of the country having hardly any patients identified and other areas having higher proportions. You've heard from Tim about the NHS long-term plan, and we were delighted when there was an ambition included in the NHS long-term plan to nationally identify 25% of FH patients by 2025. So that's only a quarter. So setting out to identify a quarter by 2025. And again, to give you an idea of what that means in practice, in a typical GP practice of 10,000 patients, you would expect that each practice would have about 40 patients with FH, who currently, the vast majority of whom are not identified or optimally treated. Next slide, please, Sarah. So to give you the local context, we had our initial pilot project, which was performed in the Durham area, and it started about 2 years ago now. We're very grateful to colleagues from Amgen and Sanofi who supported the project through joint working agreements. And that was very unusual to have two companies working in partnership with us. And that has been a phenomenally successful collaboration. We set out to get over some of the barriers that had been identified around identifying those with FH. The fact that lipid clinics are very busy, lipidologists are in short supply, and that actually the vast majority of people with this condition will be out there in the community. So the project set out to determine whether or not it was feasible to search primary care electronic patient records and then establish a nurse-led clinic to identify those at high risk of FH, to genetically test them in primary care, and then look at cascade testing family members from those initial probands identified in primary care. And Pete Carey is going to tell you a little bit more about that project in a subsequent talk. But all in all, that project has been so successful that when the AHSN network requested applications for national adoption and spread rollout programs, we felt in a strong enough position to submit an application. And then ultimately, we were one of 42 that were shortlisted and 7 that were, 42 longlisted, 7 shortlisted. And we are now one of 3 national programs that are being rolled out across the whole of England. Next slide, please. So for us, the next step is to take that knowledge and experience that we've had working in Durham and take that where opportunities may be across the rest of North Cumbria. So the team, headed up ably by Kate and Jane, Nikki, Alison, Catherine, working as well in parallel together with Michelle and others, have all been frantically process mapping the current pathways around lipid management in initially the Durham pathway, but subsequently we see that the pathway will not be universal in all areas of North Cumbria. The pathway on your left-hand side is the current pathway, and what we're looking at is how we can streamline that pathway and focus on delivering as much as we can in primary care, and getting over some of those barriers around scarce lipidologists and waiting lists around attending lipid clinics by training up new types of clinicians, such as clinical pharmacists and nurses with experience in consenting and FH testing. So harnessing resources that are already there in primary care electronic patient records, but developing new types of pathways. Next slide, please, Sarah. So at the moment, we've got some initial conversations and areas of work that are going on. We've been working with the Northumberland primary care team, the large group of practices that there is in Northumberland, who have System 1, so they've been able to do the same searches that happened in Durham. And we're now looking to work with those practices to take the lists of patients that have been generated and look at developing virtual ways that we can interact with patients in order to perform the genetic tests and subsequent cascade tests. Sunderland has predominantly got EMIS practices, and although we have the searches in an EMIS format, we haven't deployed those as yet in our region. So we're looking at trialling those in the Sunderland area. And we're having ongoing discussions with teams in County Durham and South Tees about where opportunities might lie with working with them. Next slide, please. And we're pulling together all the resources that we've used with the current pilot that has been delivered. We're looking to put most of those onto the AHSN website, but we're also setting up a future NHS Futures platform, which will allow people to share information of good practice across all of the AHSNs, but also within our AHSN. And there are so many good resources that are out there that we can harness without reinventing the wheel. One of the issues that's been identified is around genetic testing and the important counselling that's required to go along with that. And we've been working in partnership with colleagues at Northumbria University, Debbie Leatham, who's an academic there, who is creating an online resource that will train healthcare professionals to be able to deliver genetic counselling appropriately for those with who we suspect may have FH. If you want to try and access some of those resources, the website is there, or Kate, who's the North East North Cumbria programme lead, will be able to point you in the right direction. Next slide, please, Sarah. And this is my favourite slide. Kate wouldn't let me show the piece of paper that this originated from, and somebody in our comms team has made this into a beautiful infographic, as they have the skills to do. But this started off as a drawing on a piece of paper, trying to capture the team's perspective of what our North East North Cumbria programme looks like. We think of it as a piece of pizza, and it's become known now as the pizzagram. And essentially, we have our overarching CVD prevention programme, and within that are local programmes around hypertension. We've also got ongoing support that we're providing for the previous national programme of atrial fibrillation. But the vast majority of the work that we're hoping to deliver across North East North Cumbria, and what we see as our greatest contribution, is around lipid optimization and identifying those with familial hypercholesterolemia. And we'll hear more a little bit later about the tip of our pizza pie, the new pipeline medicines that are on the horizon, PCSK9 inhibitors. There are some projects that are ongoing at the minute, and there are other novel treatments in the pipeline. Next slide, please. So thank you, that's me done. I think I'm just to time, and I'll now hand over back to Jane for the next talk.
Thank you, Julia. That very nicely leads us into the next talk, which is looking at PCSK9 inhibitors in particular. Maria Roche is a clinical pharmacist by background, has prescribing experience and training. She's had a vast number of roles. I was somewhat overwhelmed by the number she's had, but she's currently the interim chief executive officer for the Academic Health Science Network in North East North Cumbria, and she's a joint national lead for the FH and hypercholesterolemia programme. Thank you, Maria.
Great, thanks, Jane. I won't introduce myself again, so I think that's an introduction in itself. Can we have the next slide, please? Okay, so I'm going to talk to you about the Accelerated Access Collaborative. So this is a dedicated and distinct unit within NHS England. It was formed in October of 2016 on the back of the Accelerated Access report that was published where the desire was basically to make the UK one of the most pro-innovation systems in the world. So it's a single umbrella body that straddles the whole UK health innovation ecosystem, bringing together industry, the NHS, patients, commissioners, etc. So you can see in this infographic here the various different players that are involved. It's chaired by Lord Darcy. The chief exec is Matt Whitty. And as I said, it's this single umbrella body that straddles the whole innovation system, which is all around improving the access for patients to innovative treatments. Next slide, please. Okay, this slide just gives you a good idea of the various different programs that are run by the Accelerated Access Collaborative. And as you can see here, they kind of span the whole innovation pathway right through from where innovation ideas are generated right through to where they're adopted and spread into the NHS. So there's a whole host of programs here, and highlighted in amber, you can see the Accelerated Access Collaborative's Rapid Uptake Programme, and also on the bottom here you can also see the National AHSN Adoption and Spread Programmes as well. So this is where I guess the two programmes that we're talking about today, that Joe's talked about and that I'm talking about in terms of the Rapid Uptake Programme, this is where they sit in the innovation landscape as part of the AAC and the NHS England programmes. Next slide, please. Okay, so as I said, the aim of the Accelerated Access Collaborative, it's all around removing the barriers to giving patients rapid access to highly innovative treatments. In terms of their strategy, so there's two kind of pillars to their strategy. So the first is all around trying to improve the pipeline of proven innovations. And then the second piece is once they've identified that pipeline of novel treatments, it's around making sure the uptake and the adoption of these treatments is effective as it possibly can be. So they've identified a number of products. They've gone through a whole due diligencing process to identify a list of products for adoption. And at the bottom of this slide here, you can see the list of products that was identified for the last 12 months to 2019-2020. And as you can see, the one I'm going to talk about is PCSK9 inhibitors. But so 7 products were identified, and they cover cardiology, obstetrics, cladribine there for multiple sclerosis, and also a couple of products in cancer. Next slide, please. Okay, so I'm going to talk specifically around the PCSK9 inhibitors because that's the one that we've been leading from North East North Cumbria perspective nationally. So PCSK9 inhibitors, they're treatments for, there's 2 drugs in this class, alirocumab and evolocumab, and they're used for the treatment of high cholesterol. So the indication is for primary hypercholesterolemia or mixed dyslipidemia, where a patient's LDL concentration is persistently above a particular threshold despite being on maximal lipid lowering therapy. So the indication is quite specific in terms of when these treatments can be used. And the companies went through an application process to have the products selected to be a rapid uptake product. And this is just a recap in terms of why they were selected. So both agents are NICE approved drugs, so they have the full evidence base of clinical and cost-effective data. They help to address a very important NHS priority, and both Tim and Joe kind of gave you the statistics in terms of cardiovascular disease and why that's such a really important area in the long-term plan. Obviously, these drugs, they treat cholesterol, and as we know with cholesterol, it's a real problem for us in the UK, both in terms of underdiagnosis and when patients are diagnosed, treatment across the country tends to be suboptimal. So these treatments are obviously a very highly effective treatment for cholesterol. Another kind of key reason was adoption within the system and across the country. Prescribing of these drugs was significantly lower than was expected. So when NICE do their assessments, they do a forecast of how much they think the product is going to be used in patients. And actually, when it was prescribed, it was found that actually the uptake of these medicines and adoption across the system was about between 70 and 80% lower than was originally forecast. So adoption was significantly lower than expected. And the last reason is that when these drugs are used as prescribed, they've been proven to be very highly cost effective in terms of reducing morbidity and mortality. So they've proven value in terms of kind of improving health gains and health efficiencies. Next slide, please. So as I mentioned earlier, the rapid uptake program is all around trying to identify the barriers to uptake and trying to remove those barriers. So I'll just very quickly touch on what for PCSK9 inhibitors the barriers have been identified as. I guess the first one there around a lack of patient identification. So prior to being included in the long-term plan, previously there were no incentives or initiatives to try and improve cholesterol management. In terms of the treatment of cholesterol across the country, the treatment pathways were quite inconsistent, and there was quite significant variation in terms of how patients were treated. With these drugs, there has been proven to be quite limited awareness of these drugs, and particularly in primary care, many GPs just weren't aware that these were available, and it was a treatment option for patients who are already on maximally tolerated lipid-lowering therapy. These drugs are classified as red drugs, which means they can only be prescribed in hospital, and obviously that limits and restricts the number of patients that access them, because capacity within lipid clinics can be quite limited. And also in terms of the treatment pathway. So to prescribe a PCSK9 inhibitor, it's quite prescriptive in terms of the bloods that need to be taken before treatment can be initiated, etc. It requires an LDL cholesterol measurement, and often that isn't measured routinely, and often in cases where it is measured, it isn't recorded. So that was a key barrier identified. And finally, in terms of complexity, lipid-lowering therapy or optimization of lipid-lowering therapy is quite an involved process. So there's multiple steps involved. There's multiple blood measurements which are required. And so it's quite complex and an involved process. And that has been identified as one of the barriers to adoption. So this slide really just is a summary of the reasons perhaps which might explain why the uptake of PCSK9 inhibitors has been less than was originally forecast by NICE. Next slide, please. So each of the rapid uptake products, which I alluded to in the earlier slides, they're led by a product working group. And the product working group is responsible for leading a program of initiatives which try and address the barriers to uptake. And for PCSK9, the barriers to uptake that I mentioned in the previous slide. I'm not going to go through all of these in detail, but these are just some examples of the activities that are led by the product working group to address the barriers to adoption of PCSK9 inhibitors. Just touching on a couple of them, the Pathway Transformation Fund is an example. And the Pathway Transformation Fund was where NHS England and the Accelerated Access Collaborative have made £1 million available to NHS organisations to bid for, to develop projects which will help them with their lipid pathways and their lipid clinics. So 19 sites applied for this funding and 13 were successful in receiving funding. And the monies are being used to resource things like extra pharmacists or extra capacity within the lipid clinic, or to kind of fund systematic searches. So I'm not going to go through all these because I don't have time, but basically these are examples of the initiatives led by the product working group to support PCSK9 inhibitors. Next slide, which I think is my final one. Yeah, so I took it out, but basically just to say that, so PCSK9 inhibitors were selected as one of the rapid uptake products for 2019-2020. And in the last few weeks, this PCSK9 inhibitors has been expanded to also include high intensity statins and ezetimibe. So for the next 12 months, this product working group will support the full lipid portfolio of drugs, so high intensity statins, ezetimibe and PCSK9 inhibitors. and so effectively supporting the full lipid management portfolio.
Thanks, Maria. That's very helpful. We're going to move on now and move away from lipids for a short time. The atrial fibrillation was, as you heard from Julia, was the national programme for the AHSNs most recently, and there are some legacy aspects of that that we will continue to look at within the CVD prevention programme going forward. Kate is our programme lead for that. She has extensive experience working in health. She's worked in research, clinical audit, and health improvement, and is extreme. And she's going to talk to us a little bit more about atrial fibrillation as it is now.
Thank you very much, Jane. Can everybody hear me? Hopefully. Thinking about, can I have the next slide, please, Sarah? So there was a national AF programme that ended March this year, but it was a 2-year programme that was mandated by NHS England and was rolled out across all the AHSNs in England. The programme essentially was about reducing AF-related strokes and doing this through finding those patients who have asymptomatic AF who are currently undiagnosed and ensuring those that do have a diagnosis of AF were optimally treated. So thinking about that, where are we now? QOF was actually released earlier this year. So 2019-20 QOF, the AF prevalence for the North East and North Cumbria was at 2.34%. So that was up from the previous year of 2.25, with an extra just over 3,000 patients added onto the AF register lists in primary care. That data was through NHS Digital and relates to the 8 CCGs within North East and North Cumbria, including the merged CCGs, but not including Hambleton, Richmondshire and Whitby, who are now no longer part of the North East North Cumbria patch. Can I have the next slide, please, Sarah? Thank you. So where are we now in relation to anticoagulation? So again, same QOF period 2019-20. All of the CCGs in our area are above 85% in terms of anticoagulation, and the average North East North Cumbria rate is 88.2%. This data includes all the data, so there's no exception reporting that's within the data. Thinking a little bit further back, the QOF data for 2017-18 showed that the average North East North Cumbria anticoagulation rate was 84.34%. So there's been a lot of work done across the system within the area to increase numbers regarding anticoagulation. Can I have the next slide, please, Sarah? As you'll remember from Julia's presentation when she showed the pizzagram, a small element of the CVD programme will include atrial fibrillation. So thinking about the next 3 years and moving forward, what are we planning to do? So AliveCore is a small mobile ECG device, one lead, and we had 470 devices across the patch in North East North Cumbria. That was a combination of NHS England funded devices and AHSN funded devices. So they've been used for the last over 2 years now, probably nearly coming up to 3 years, but we have data to have a look and to see how that has been performing. So from April 2018 to June of this year, over 50,000 traces have been taken using these devices. We know that there is a possible up to 3,500 possible AFs detected. We don't know that for definite because those patients that have a possible AF detected need to go on and have a 12-lead ECG to confirm or refute that potential diagnosis. If all of those people did actually have an AF, did go on and have an AF diagnosis, we would have saved over 170 strokes, and that's based upon 1 in 25 patients who have AF that aren't treated will have a stroke. And if you extrapolate that up in terms of cost, that's over £7.5 million, and that relates to combined health and social care costs over 5 years. So we want to continue supporting this work, and one of the things that we plan to do is a Train the Trainers programme. and have a campaign. So that's likely to be launched in next year, but that will be around supporting people on local patches if they want to support other people, so at CCG, PCN level, giving them the benefit of our experience, our resources, and supporting people to be able to do that on the patch. And next slide, please, Sarah. The other element of detection was around AF diabetes podiatry. Patients that have diabetes have an annual check, and as part of that annual check, if you are over 12, you have your feet examined, and foot pulses are examined as part of that check. Podiatrists are not generally listening for regularity or irregularity. However, a pilot piece of work in County Durham and Darlington that trained podiatrists to listen to regularity found that for every 500 patients seen, you could find one new patient with a diagnosis of AF. And that work has been very much supported by the College of Podiatry and NHS EI Clinical Network, specifically the Diabetes Foot Care Network. And that work is now started to be spread, certainly across North East and North Cumbria, but we also know of places in Yorkshire, Manchester, London, Torbay in the southwest who are taking this on. And it builds upon very much about what Tim had said about making every contact count. We have won an award for that through the AFA, the Atrial Fibrillation Association Healthcare Pioneers Award in 2018, and we were shortlisted this year for the Advancing Healthcare Award for the Faculty of Public Health and Public Health England's Award for Contributions to Public Health. Essentially, what we would really like is for this to become standard practice across the country. So we will continue supporting that. Next slide, please. So moving forward, thinking about anticoagulation, this is some legacy work here. So there was some work around the Southern, what we call the Southern Collaborative AF project, which is some work across Tees Valley and County Durham CCGs. And this work was about to be started just as COVID hit, so obviously has been paused. And this was some joint working arrangements between industry, the AHSN and the CCGs, with funding put into a pot to make sure that this can happen. We would expect that this work to be picked up in 2021. The post-virtual clinics work, 3 areas within the North East and North Cumbria, North Tyneside, Northumberland and North Cumbria CCG areas, were part of some work funded by NHS England around AF virtual clinics last year. It was a year's piece of work that ended in March this year. And what we were in discussions was really about trying to sustain that work beyond the time-limited period. And that would really be looking at some work and offering a suite of a menu of different things around systems, education, quality improvement. We are waiting really to, obviously that work hasn't happened yet. It's being funded through a MEGS, a Medical Education Goods and Services grant. And when the time is appropriate, I'll be picking this back up, and that will be up to the CCGs about how they would like to take that work forward. Some of you will be aware of the AF card deck that we have. This was a small sort of A5 pocket guide that went to all GPs across the North East and North Cumbria. We are now on our 2nd edition, and that was due for review at the end of March. We were aware that NICE were updating the guidelines that were due to be out this autumn, but understandably has been delayed until February, although it's out for consultation at the moment. Once that's released and published, we will be updating the AF card deck so that people will have an up-to-date resource. Next slide, please. Essentially, what we're wanting to do with AF is to build upon the work that happened in the 2-year national programme and ensure that it's sustainable and the work continues on into the future and leaving a legacy from that work. Thank you very much.
Thank you, Kate. We're going to move on now and talk about the pilot project that Julia mentioned with regards to familial hypercholesterolemia, the one that was done in Durham. Dr. Pete Carey is a consultant in diabetes and endocrinology who works at South Tyneside and Sunderland, but has been very influential regionally with regards to lipid management and this particular pilot study. So Pete's going to talk to us about that. Thank you, Pete.
All right, thank you. Hello, everybody. Can I have the next slide, please? So just to give you a little bit of background, we've been undertaking FH genetic testing in the North East and North Cumbria since mid-2014, and we were one of the first regions in the area, in the country, to start with FH genetic testing. And I think that pays tribute to all the work that had been done regionally by Dermot Neely. Historically, within the North East and North Cumbria, genetic testing has been more established within the north and the west of the region, and that's for a variety of reasons. And what we were able to do initially was get funding for genetic testing through the Applied Health Sciences Network and funding for FH genetic nurses from the British Heart Foundation. We got an initial funding for 3 years, and then when we approached the CCGs to arrange ongoing funding, there were negotiations held with various members of the CCGs about how we could develop this further, and in particular Durham and Darlington were keen to develop more testing within primary care. There was previously an audit taken place in Medway in Kent, which had shown that when they undertook systematic searches of primary care records, they could improve the diagnosis rate of FH based on clinical criteria. But crucially, what that project didn't do was to move forward with the next step and do FH genetic testing. On the back of the Medway project, NICE altered its FH guidelines to recommend doing systematic searches based on age criteria. So they were recommending searching primary care records for people under the age of 30 who had a cholesterol greater than 7.5, which is the usual cutoff that we would use for the Simon-Broom criteria. But also they suggested that patients who are older, over the age of 30 years, should be investigated for FH if they had a cholesterol greater than 9.0. So based upon the negotiations and what we knew, the aim was to undertake a pilot study in the south of the region around Durham and Darlington to see if we could increase the detection rate of FH in primary care. And it's interesting, I was looking back on some notes that were done by the lead nurse that did this project, Lorna Ingo, and she's been essential to this. The initial aim was to try and identify 20 patients who would be suitable for FH genetic testing. So we were hoping to find 20 patients, and then from that identify 6 or 7 index cases with whom we could find a confirmed mutation. And then from those 6 or 7 index cases, find a further 12 to 14 relatives through cascade screening. Next slide, please. So the first phase of the project was done in 4 practices. There was one practice in Newcastle, and then the other practices were around the Durham and Darlington area. So the combined population of those 4 practices was just over 45,000. And based on an incidence of 1 person with FH per 250 people or 250 population, we would expect those 4 practices to have a combined population of 180 patients who would have FH. As things stand, only 6 patients had a confirmed diagnosis of familial hypercholesterolemia, having undergone genetic testing. So that shows you how far we have to go in order to try and improve the diagnosis of FH from where we are at the present time. There was 1 patient undergoing testing, but they turned out to be negative, so that didn't increase the number. From the searches that were conducted using the FAMCAT tool, we found about 303 patients who were very high risk. The FAMCAT tool had been developed at Nottingham University, and so that was an off-the-shelf search tool that we used in the first instance. Of those 303 patients who were very high risk, 43 patients or 14% of those patients were invited to attend screening as they were thought to be eligible for FH genetic testing. And as you can see, that's quite a low number of the total that we identified. Of those 43 patients, only 21, only half actually turned up for their nurse-led appointment, and this occurred before the COVID-19 pandemic. So this wasn't affected by COVID-19. And then of those 21 patients, only 12 were eligible for FH genetic testing. Of those 12 patients, 25% or just a quarter had a significant result. 1 patient tested positive with a confirmed FH genetic diagnosis, and 2 patients had what we called a variation of uncertain significance. That is, 2 patients were found to have a genetic variant which may or may not be causing familial hypercholesterolemia and requires further investigation. Those 3 patients had between them a combination of 28 first-degree relatives and 77 second-degree relatives. we would expect half of the first degree relatives to have a mutation and a quarter of the second degree relatives to also have the variant. So of the relatives, we would expect a further 33 patients to be positive for either the known mutation or the variation of uncertain significance. Next slide, please. So following the first phase of the study, we had a bit of a stock take and assessed where we were. We had some issues with the FAMCAT tool. First of all, the FAMCAT tool used the hard drive of the GP IT systems and wasn't really integrated with the practice medical records. And that made it impractical to use as it presented a security challenge. There were a large number of patients who were identified on the searches who were not eligible for FH genetic testing, primarily because they had underlying secondary causes, such as diabetes or on various medications that caused their triglycerides to be raised. Crucially, although the searches have suggested to identify patients with high cholesterol, it's uncommon for patients with familial hypercholesterolemia to have high triglycerides. Raised triglycerides usually mean that you've got an underlying diagnosis of familial combined hypercholesterolemia or have secondary causes, and those patients are unlikely to have a confirmed genetic mutation. We vet patients using the Simon-Broom criteria, and then we use something called a Dutch lipid clinic score to vet those patients to find those that would be eligible for genetic testing. And I'll be talking a little bit more about the Dutch lipid clinic score in the breakout session that I'll be doing later. But suffice to say, as part of the Dutch lipid clinic score, we exclude patients with raised triglycerides. So the FAMCAT tool wasn't really doing that for us already. So Lorna, as the nurse, was having to triage large numbers of patients and remove the patients with high triglycerides as they wouldn't be eligible for genetic testing. This was very time consuming and generated, in the end, very low numbers of patients who are actually eligible for genetic testing. So we then spoke to Gareth Forbes, who is a GP who works over in Durham, because he's been developing searches primarily within System 1, and he developed a new search tool for us based primarily on the NICE criteria of a cholesterol of greater than 7.5 in those under the age of 30, or a cholesterol of over 9.0 in those over the age of 30, and modified those based on non-HDL and LDL readings, but crucially also incorporated a factor 2 into the search, so it was exclude any patients who met those criteria but had high triglyceride levels. In addition, we also included patients who had a personal history of premature cardiovascular disease. Now, for the Simon-Broom criteria, we would normally want to find people, patients who have a first-degree relative with a myocardial infarction before the age of 60. But if you include patients who have premature cardiovascular disease under the age of 50, that means that both their first-degree and secondary relatives could potentially fulfill the Simon-Broom criteria. And using a cutoff of less than 50 for premature cardiovascular disease also reduced the numbers that we were dealing with. Another important development that we used for the second phase of the study was we got feedback from patients, because obviously it's all very well identifying the patients, but if the patients don't come to their appointments, you can't then arrange for them to have genetic testing. So we made changes to the patient literature so it was easy for them to understand what we were trying to achieve through the searches. And we also started to telephone the patients before the meeting with the FH specialist nurse so that we could discuss the rationale for inviting them to the appointment and explain what it was for. And that meant that patients were more likely to come to their appointments. Next slide, please. So we then tried the second phase of the study. I've actually said there were 5 practices. In fact, there were 4 practices. One of the practices was over 2 sites. And again, this had a population of around 49,000. And again, based on the prevalence of FH, we would expect there to be 197 patients with FH. Again, there was quite a low prevalence of patients with a confirmed genetic diagnosis among those practices. But using the new CDRC searches, which were developed by Gareth Forbes and his team, we identified 126 very high-risk patients. Of those, quite a high number, 71, so over half, were eligible to be invited to attend for screening. And again, we were able to improve the number of patients who attended for their appointments. So we got almost 3/4 of patients to come to their appointment. I think what shows how well this works is of those 74 patients who attended, 53 were eligible to undergo FH genetic testing. 2 patients decided they didn't want to have genetic testing, so we had 51 patients who were tested. Of those 51 patients, 24 had a significant result. 22 patients had a genetic mutation, and 2 patients again had a variation of uncertain significance. Interestingly, when we retrospectively went through the data, we found that we actually had found 6 members of one family who all were identified. And I think this is important because it shows that the searches work and that they identify patients who have got FH. But one of the things that we need to refine going forward is trying to consolidate the knowledge that we have from local practices. So when we get local knowledge, people can say, okay, I know that this patient has an Auntie Nellie who's also been identified from the searches. So in total, we had 19 indexes that were identified across the practices. And again, looking at the relatives, these 19 indexes had 50 first degree and 89 second degree relatives. And we would therefore expect a further 47 patients to test positive if we were able to cascade all of those relatives. And I think another key takeaway message from the second phase of the project was that all of the practices that were involved with this, these searches had a minimum of at least 2 patients per practice. And one of the practices had more patients, and because they already had a high number of patients diagnosed, they were approaching the new NHS long-term plan of having 25% of patients expected to have FH being identified. Next slide, please. So just to summarize, we've now developed an optimized pathway for identifying FH based on systematic primary care searches. We've incorporated patient feedback to improve patient awareness and crucially get bums on seats and get patients to come to these appointments. This process allows guided FH genetic testing and cascade screening of relatives. This can be done within primary care and therefore frees up resources within secondary care clinics. The searches have now been developed both for use in System 1 and in EMIS, and our aim going forward is to try and help practices meet the NHS long-term plan target of improving FH diagnosis rate to 25% over the next 5 years. Thank you.
Thank you, Pete. That's a very good overview. We're going to move on now and talk about the primary care perspective with regards to cardiovascular disease risk and the holistic approach to the detection and management of that. I'm very happy to welcome Dr. Guy Pilkington, who is an experienced GP working in Newcastle, but who's had a number of other roles, both within the CCG and also more regionally. Thank you, Guy.
Thanks, Jane. Thanks very much. I've kind of got the graveyard shift to these 10-minute presentations because after me, you're going to have Jane giving everybody an opportunity to reflect on what you've heard. And if I reflect on what I've heard, and I've been involved with a lot of the individuals who presented so far today in that story, particularly around familial hypercholesterolemia, the thing that most obviously strikes me as a GP working in a busy general practice is how do we stop what we are hearing today from feeling overwhelming? It clearly, as Tim said right at the start, if we are concerned about the health of the people that we look after and the populations in the Northeast, it does us no harm whatsoever to have a really strong laser-like focus on cardiovascular disease. Why? Because it's the commonest cause of morbidity and mortality across the country, and therefore we have lots of it in the Northeast. But also, as Tim pointed out, it is one of the key drivers of unequal health outcomes. And as he made reference to, there is no question that the impact of the pandemic is having very unequal effects on the populations that we look after. So I suppose what I would like to give you is a few minutes to catch your breath and hopefully to perhaps put some of it in context and feel maybe you can see how you can make a contribution to this regional challenge that we'd like to all contribute to. Can I have the next slide, please? One of the roles that I have that Jane referred to, I used to chair the CCG, and although it says in the literature I'm chair of the CCG, I'm not, disclaimer. I was, but for a couple of years now, my main role at the CCG and regionally has been to chair the prevention board for the North East and North Cumbria. So we have, you know, a leadership role in bringing the system together to do what Tim referred to, reduce the gap in healthy life expectancy across the region with the rest of the country. There are about, I think off the top of my head, I think there are about 5 or 6 local authority areas in the Northeast where healthy life expectancy is less than 60. And as part of the response in our Northeast response to the long-term plan, we have committed to raising every area's healthy life expectancy above 60 within the next 5 years. So that's a big ask. As part of the prevention board, we have a strategy that focuses very heavily on tobacco harms, alcohol harms, workplace health, social prescribing, and the community assets that are out there. You know, I'd like you to be able to think about the kind of things that I'm going to talk about in terms of how you could think of ways in which to contribute to the prevention agenda, the inequality agenda, understanding that, of course, a lot of the things we've heard about come as primary prevention, but a lot also as secondary prevention. When we find our diagnosed hypertensives, as Tim said in the beginning, we're doing quite well, but let's make sure that we are treating to target. Let's make sure that we are treating lipids to target and reducing the LDL cholesterol by more than 1 point, but each point offering massive reductions in cardiovascular risk. So think about your prevention in terms of primary and secondary, and the number of ways in which we as GP practices contribute to that. I'm going to talk a little bit about how having the register and having a population and thinking about that register as a population can open up possibilities of different ways of tackling the challenge we face. And then knowing that we've spent a lot of time talking about hypertension, atrial fibrillation, and familial hypercholesterolemia, which are really the 3 major contributions that we can make as GP practices, I do still want to talk about smoking, which featured 4 or 5 on that histogram that we saw at the beginning. So that's what I'm going to be doing. Next slide, please. Population approaches. QOF, love it, hate it, we live with it, and it has done some very important things, I think. It is a quality improvement tool. It is a way of getting us all to focus on some evidence-based interventions, and actually probably the least controversial elements of QOF when it first came in were all about the cardiovascular secondary prevention that was available to us, getting our registered patients with known ischemic heart disease or vascular disease on statins, getting their blood pressure checked and treated, getting smoking interventions going, and so on. I think QOF, as we all know, has struggled year on year as they attempted to try and find what those key measurable and important interventions were, and we all kind of lost faith in the QOF model as we were being pushed into areas that felt, frankly, as if they weren't adding much value. But I think it is, and in cardiovascular disease, it remains an important tool. So scrutinizing your register, understanding where you're missing the QOF points, particularly around cardiovascular disease, thinking of quality improvement projects, all of which, of course, looks good when CQC come knocking, as they will do once again in the near future, I'm sure. And doing that audit cycle does lend itself well to topics around what you've heard today. Getting on board with the AHSN around optimizing lipids and finding people with FH would be a really good way of quickly being able to demonstrate that you are interested in quality improvement for your register. And as we heard from the presentations earlier, there is no way that you're anywhere near knowing the number of people that we want to we want to eventually know about people who are living with genetic FH. I was involved with Dermot and Peter and many others right at the start of the FH project, and I want to make particular reference to the nursing cascade team that has been initially hosted within Sunderland and now within the Northern Genetics Service. That cascade testing, when you see the numbers that Peter put up, 50 first and 89 second degree relatives that will lead to an additional 50 odd diagnoses, they are doing fantastic work across the Northeast. And every time you or your practice contributes by finding an index case for FH, you will be producing life-changing interventions for their relatives as well as that individual. And so it's a fantastically exciting way of getting into primary prevention for something that does kill people far too young. But for us, the screening approach around cardiovascular disease very, very much comes back to another of our familiar primary care tools, the NHS Health Check. Again, something that hasn't universally been welcomed as a good screening program, mainly I think because there is an inverse care law, and that the people who are most likely to turn up for their NHS health check are the least likely to need it. And that inverse care law plays out across our areas, because we know that the Northeast lives with very significant deprivation gradients from the poorest areas of the Northeast through to the most affluent. And as a result, the NHS health check has come into a little bit of bad press. However, if you are working in an area of deprivation, if you are looking after people with poor health outcomes as a population, this is not a bad tool to try and invest energy in, because it covers the ground of the things that we heard right at the start, which are most important: the blood pressure, the lipids, smoking history, and so on. I think now that COVID and the pandemic has arrived and we're all working extremely differently, we do have to think about how we're going to move from being reactive to proactive about this. We know that people are avoiding coming to see us. We know that there are harms going on in the background that we are not aware of. And if COVID harms are on a gradient that follows the deprivation gradient, we certainly know that non-COVID harms are also occurring along that gradient. So how do we as GPs and GP practices, how do we begin to go out and change the way in which we will interact with people that gives us a fighting chance of increasing the diagnoses of hypertension, for example, going right back to the beginning? If we're not going to see people in our surgeries very often, how on earth are we going to find the people who are living with undiagnosed hypertension? And therefore, we need to all, as organizations, pay some attention to thinking about how we work differently. Case finding, very important approach, and the best example I can think of is the one that you've been hearing about around familial hypercholesterolemia. There will be opportunities for you to get on board, whether you're a System 1 or an EMIS practice, with the kind of screening tools that would allow you to work with the familial hypercholesterolemia nursing team to think about how you could scrutinize that register using the kind of tools that have come out in the Northeast. But then I think the other big opportunity for us is around networks and the new network roles that are being created within primary care networks. And health coaches, for example, are one of the roles that we can begin to employ people for. if we have a small army of skilled lay individuals who can cold call, then we need to think about who are they going to cold call and why. And I'm going to give you an example around tobacco that will give you some idea, but you can do this for other things. There's no reason why we can't cold call people whose hypertension needs improved management. There's no reason why we can't begin to invite people in for NHS health checks supported by health coaches explaining to people why it might be worth them visiting the practice. Next slide, please. I'll finish off now by talking about tobacco specifically. It clearly is a major contributor to the cardiovascular burden of the Northeast and continues to be so. And yet in primary care, there is clearly very strong evidence base that very brief advice from primary care has an impact and makes a difference. So this is where the making every contact count methodology comes in part. Think about the staff in your practice and whether they are delivering very brief advice. You can get training tools and e-learning modules very quickly through, I can't remember what the NCSCT is, but it's something and it exists and it's got all sorts of training modules there for people. And if you do that, they become confident in ask, advise, and act. You would clearly have to work closely with your local authority provided smoking cessation services, but I think this is something worth considering as practices. Next slide. Next slide, please. In the West Midlands many years ago, 2015, they did this in a practice of about 5,000 patients. And some interesting statistics that came out of this. They looked at their smoking prevalence, they approached their smokers and they proactively contacted them and they engaged as many as possible in quit attempts through local smoking cessation services. And by doing that, they had a significant impact on their prevalence. They reduced their prevalence from 23% to 17%. And those people who gave up used their GP practices less. So there's an attraction for us. We'll never actually notice because we'll still be busy looking after a lot of other people. But it is interesting that if you can encourage people to give up tobacco use, they will eventually need you less frequently. And that has to be a good thing. So although the trouble with these studies is always, when do you notice the change? If it created 20 extra appointments per week, unfortunately, the GPs in that practice won't have sat there with empty surgeries. They won't have noticed those 20 appointments because they'll be filled with something else. So we've got a long way to go before that ever happens, I suspect. Next slide, please. And if all of that feels like that's an impossible thing to do, we have in the Northeast and North Cumbria, along with the local authorities, all committed to attempting to get our region down to 5% smoking prevalence by 2025. We're off trajectory, but we have been catching up with the rest of the country in terms of smoking prevalence. And if every practice in the country did a little bit of cold calling and proactive encouragement through very brief advice methodologies, we know that that would make a significant contribution to our eventual target of 5% by 2025. I think the next slide's the last one. And this is just to remind people that nothing is equal when it comes to the deciles of deprivation. These are quintiles actually from national data, and it shows that the more deprived areas, of which we have many, have higher rates of tobacco use and higher rates of tobacco harm. And therefore, if you are working in areas of deprivation, what you can do to contribute to that is even more important than in other areas. So I think that was my last slide. I suspect I've talked too long, and I apologize for that.
No, that's fine, Guy. Thank you very much indeed. I've been keeping an eye on the time, and I've also been keeping an eye on the chat. I can see that actually, as people have been speaking, there've been a number of questions coming up, and I think they have largely been addressed actually. So I think rather than delay breaking for the comfort break, I'm going to suggest that if there are any questions that haven't been addressed during the chat, during the talks, then we'll pick up those later. And of course, you can always contact either our AHSN team here or your own local AHSN teams if you happen to be outside North East North Cumbria. But we're here to help if possible.